Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, July 24th, 2023. I'm joined today by Dr. Basma Faris, who is an OBGYN, a colleague, and a friend. And we're going to talk about polycystic ovarian syndrome, or PCOS. PCOS is a common condition that manifests usually with irregular periods and increased androgens, but can vary significantly from person to person. Basma is an expert in this condition, and she also recently launched a new venture where she provides comprehensive care to people with PCOS. You can check out her website, and we give you the website during the podcast, but if you want it now, it's www.polyprepmd.com. That's poly with two L's, POLLYPREPMD.com. Cool stuff. All right. Few things. Reminder, for all of you listening on Apple or Spotify, we would love it if you could rate this podcast, preferably with 5 stars. Also a reminder to please send us any questions you might have for our mailbag podcasts. We had our second mailbag podcast last week. Response was great. The questions have been awesome, so keep them coming. You can either email them to us at hw@healthfulwoman.com, or you can go to our website, www.healthfulwoman.com, and click on the link that says send us your questions. Also, big news for those of you who have not yet heard. Emily Oster and I wrote a book together. Amazing, huh? And it's coming out in April of 2024. It is called The Unexpected: Navigating Pregnancy During and After Complications. You can pre-order it pretty much wherever you order books online. We also dropped some links on our social media and added one to our website. So please do check that out. I think it's a good book. All right. Thanks for listening. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Basma Faris, welcome to my podcast. I love having you here.
I'm so excited.
It's so nice to see you in person again. It's been a while.
It's been a while.
Yeah, it's crazy. We obviously go way back, and we'll get into that in a good way. And you are also an OBGYN at Mount Sinai on the west side, which is where I and my practice will be migrating in a few months. So we'll be reunited together again.
Looking forward to it.
Yeah. And Melka suggested that we talk for the podcast, which is great. Melka's always, she's like my agent.
Well, she does a good job.
She does a good job. So who are you? What's going on? Who are you? What's your career? Talk to me.
So I'll just really brief because it's long, but I started my career in healthcare as a registered dietitian. So I studied nutritional science at the University of California at Berkeley, where I just really fell in love with the topic. I just really nerded out on the nutritional biochemistry and just loved how it, applied to real life situations and applied to humans. So I decided to become a registered dietitian.
How did you make that decision? The original one, like what led you to go into that versus something else?
I was just taking different classes as an undergrad. I always knew I liked science. I was so on that science track, and I took intro to nutrition, and I just thought, yeah, this is it. Like, this is really cool. I really want to spend the rest of my 4 years studying this. And there were 2 routes. So you could either take the route that led you into research, or the dietetics route, which would lead me into being a dietitian. And so that's the route that I chose. And I moved back home and enrolled at Brooklyn College, where I got my master's in nutrition and became a registered dietitian. And I did that for a few years before I felt the pull to do something more with my life and decided that med school was the best choice. So that wasn't my intention from the beginning. And so in total, I worked as a registered dietitian for about 10 years.
Wow. Now, how did you decide, this is amazing in all this, the question that I'm most curious about, how did you decide to go to California? That's not so typical for someone coming out of,
It isn't.
New
but
York.
My dad went there.
Oh, okay.
And
fine.
I was born there.
And
then we moved to New York when I was an infant.
Okay.
So it's not that. I had roots.
Okay.
Correct.
Got it. It didn't just come out of nowhere. Hey, I think I'm going to Berkeley.
Yeah.
Okay. So you worked for a while, then you decide to go to medical school. How did you make that transition? Because you probably have to go back and do classes, or did they accept your your pre-med courses from back when you were in college? How'd that work?
Yeah. So I think most people don't realize to become a registered dietitian, it's actually a pretty rigorous curriculum. And it's almost identical to the pre-medicine curriculum with the exception of physics. So that was all I was missing.
And the people you're studying with are a lot nicer.
Yes, that's true. That's true.
I've been in a pre-med lecture hall, and it is kill or be killed.
Yeah. So it was definitely like a nicer, smaller vibe, more women in my classes. So I had to go back and take physics, which I did. Incidentally, I met my husband in that physics class.
Wow. Game
so
on.
Even if it didn't work out for med school, I got something out of physics, but it worked out. And
during the whole magnetic attraction part of physics?
Correct.
All right.
Exactly.
How about that?
So,
all right. That was pretty lame.
It.
That's pretty lame, but that's how I roll. All right. So you took physics, you applied to med school, and while you're in med school, are you still working or are you just shifting? I'm a med student.
I did work on the side. I lived next to the JCC, and that was where I had my gym membership there, and I saw some clients on the side there while I was in med school.
All right. So now in med school, what was your thought going into med school? Are you going to sort of parlay your nutrition into something in your medical career? You're like, or I'm totally sort of like pivoting into a different type of career.
I intended, actually. I thought I was going to be an endocrinologist or a gastroenterologist, right? Which makes sense.
Yeah. Food, gut, all that stuff.
All of that stuff.
Okay.
But then, somehow as it happens in med school, you find that you're good at different things or different things interest you. And OBGYN was that thing for me. So
really, it just
clicked.
Floated your boat.
Yeah.
Wow. Amazing. And then, of course, that led you to the great Mount Sinai.
Correct.
Wow. And that's where we met. I obviously remember that, but I can't remember the years of when you were there versus how long I'd been there. But it was some time ago.
Yeah, so I graduated from residency 10 years ago.
Right. Okay. So I graduated from residency. What year are we now? 2023. So I graduated from residency 18 years ago. So I was 5 years into being back for my fellowship. That seems about right.
Yeah.
Yeah. For the record, she was a good resident. All right.
Thank you.
All right. So you do your OBGYN residency and you're going through it and then keep going.
So I was working in a family health center in Brooklyn and just kind of trying to figure out how I was going to incorporate my love of nutrition and my background together. And I would do it in my own way in just seeing patients in the office on the regular, but I wanted to make it more formal. So I went and I did this certification program in culinary medicine, which if anybody's interested, it is sort of a postgraduate certification that physicians and other health professionals can do to learn about basically applied nutrition. So how do you apply the science of nutrition to disease and to food? So you get to learn how to cook too. So it's really fun.
I was going to ask for culinary medicine. Well, first of all, how long does that take? I guess it's not full time because obviously you're still working.
No, so it's continuing education. So it's 60 CME credits.
Oh, okay. So it's
a fair amount, and you do it over the course of 2 years, and there's an exam at the end of it.
Yeah.
And many of those CME credits are actually hands-on in the kitchen.
Yeah, I was going to ask what proportion that is actually like cooking and versus reading and hearing lectures.
I think it's about a third.
Wow, that is so cool. Now, the other thing which I'm sure but our listeners might not know, is that you're in the practice of medicine, you're seeing patients, and you have all this knowledge and experience in nutrition and being a dietitian, and most doctors have none or minimal.
Or very little.
Yeah. I mean, it's I don't want to say it's abysmal because it's very hard. It's a whole science and you have to also learn medicine, but it's much less than you might think, which is why most doctors, if they need to sort of get into that, will often refer to a dietitian, registered dietitian, someone who's trained in that specifically. So I'm sure you noticed that, but in your own practice, were you able to incorporate it?
In small ways. I sort of came up with my own screening questionnaires that I would use with all of my patients when I was doing, let's say, an annual or seeing a patient for the first time.
Right.
Just in the way that we do depression screens or screening for, substance abuse. I would have my own little, few questions that I would try to screen for and give advice wherever I could.
Tell me about your lunch. Yeah.
Yeah. I mean, sometimes it would be, very specific like that. It's challenging. When you're in an office in the current system, you don't have a lot of time. Yeah. And there's a lot that we have to cover. Yeah. And so I would find that, challenging.
Okay. So you decide to do the culinary medicine. And was that, how eye-opening was that for you versus sort of reinforcing?
For me, it was reinforcing.
Okay.
I think for somebody who has less nutrition knowledge, it's probably quite eye-opening. But for me, it was more of a refresher and sort of got me in the room with like-minded people, which is always a good thing.
Okay. And so how did you decide to use that in your career?
So, there's a few different groups. Like as a generalist OBGYN, I'd see patients who are pregnant, trying to get pregnant, or people coming in with various different conditions. And where I found I was spending the most time was with my patients with polycystic ovarian syndrome. And because it's a condition where nutrition is a big part of the management of the disease. And also because I found that for many of them, I was the only person that was, going through that stuff with them. And so, I decided to just hone in and focus on that a little bit more.
Right. So what I want to do is we're going to sort of pause your story and what you're doing, and we're going to talk about PCOS itself. So number one, so our listeners can get a sense of what you're doing. And also because a lot of them are going to be interested in what is PCOS, how does it manifest, who gets it, what do we do about it? So let's talk about that. So how do you explain to people, you're at a party and a friend says, oh, PCOS. What is that?
What is that?
Yeah.
I always start by saying it's a terrible name for what the condition actually is.
Yes.
PCOS stands for polycystic ovarian syndrome. And that name comes from the appearance of the ovaries on ultrasound in some people that have polycystic ovarian syndrome. It appears like there's lots of little small cysts. But really what it is, it's a hormonal disorder that's complex and affects many, many different organ systems. So it applies to gynecology because it can cause people to have problems with ovulation. They don't ovulate regularly. They may ovulate late in their cycle, and that can result in irregular menstrual periods or infertility. But it also affects the skin. People have acne. They have facial hair. They may have balding in a more of a male pattern. People with PCOS have the vast majority have insulin resistance, which is a pre-diabetic condition, higher rates of anxiety and depression. So there's many different organ systems that are affected by this one condition that itself also has many different underlying causes.
Yeah. And it's also one of those really interesting things where you could have 10 people with PCOS and each of them manifests very differently. And when I speak to patients about it, one of the things I say is one of the secrets in medicine is if there's an S, if we call it a syndrome, it means there isn't like a specific definition or diagnosis, and we sort of don't understand. Meaning no one says you have hypertension syndrome, right? You measure someone's blood pressure, it's high, they've got hypertension. Like it's pretty cut and dry. Whereas polycystic ovary syndrome and other things are syndromes, it's like, well, there's like 15 things that are on the list. And if you have like 6 of them, we'll call you as having the syndrome. And if you have 4, we'll be like, you're sort of like the syndrome. And if you have 12, you have a bad case of it. But it's not like you can just go and get an x-ray or a blood test or an ultrasound that'll say polycystic ovary syndrome positive or negative. It just doesn't work like that.
Yeah.
And the other reason, like you said, it's confusing because I do a lot of ultrasound. You can have the syndrome and not have polycystic ovaries, and you can have polycystic ovaries and not have the syndrome.
Correct.
So it's pretty poorly named.
It's poorly named.
Go doctors. Good job.
I think probably as we learn more about it, it'll probably, we'll discover that it's a bunch of related, distinct conditions that have similar presentation, but we don't know that right now. So
you mentioned a lot of the ways it can manifest. What is sort of the most common thing that that'll bother them or they'll complain of to their doctor or whatever it is that will lead to a diagnosis of PCOS?
From the gynecologic perspective, right? People will come into our office complaining of their periods late, it's irregular, sometimes it's heavy, sometimes it's light, they don't know when it's coming, they may not get it at all. Or they're trying to get pregnant and they're having difficulty. So those will be like the most common presentations. But people sometimes will present to an endocrinologist because somebody told them that their sugar is high or they're having difficulty losing weight. Or they may start at the dermatologist's office because they're seeing somebody for their acne or their facial hair growth. So it really kind of depends usually on their most bothersome symptom.
Yeah, and it can happen in teens, it can happen in adults. It crosses a lot of or potentially crosses a lot of specialties. Pediatricians can see this, internal medicine, obviously gynecologists, endocrinologists, cardiologists, dermatologists, a lot of people might be diagnosing this. And it is really pretty common. This is not a rare situation. A lot of people have this.
Current estimates are that 12% of reproductive age women and people with ovaries have PCOS. And that's probably an underestimate.
Yeah.
So that's a huge number. That's something like 5 million Americans or something.
That's a lot of people.
It's a lot of people.
And not only is it something that can be like annoying, right? In terms of like, I don't want to have an irregular period, like that's annoying. Yeah. And that could be sort of practically a problem in the now, meaning I'm having a hard time getting pregnant and I have to get my cycles regular in order to do that. But also there's potentially long-term health consequences to it, right?
So, 75 to 95% of people with PCOS have insulin resistance. Mm-hmm. And insulin resistance is a pre-diabetic condition. So, apparently about 50% of people with PCOS will develop type 2 diabetes before the age of 50, which is a staggering number also. Yeah. And then there are higher cardiovascular disease risks. If untreated, there's higher risks of endometrial cancer, which is a type of uterine cancer. And so it's important that people understand these risks and manage it like a chronic health condition so that they can decrease their health risks and not just attack each of the symptoms that they're having. And so that's why I think it's important, that we get the word out so that the pediatricians and the primary care doctors that are seeing these people are diagnosing it early and getting these patients the care that they need.
Yeah, I mean, like you said, it's really a global problem that can manifest in many different ways. The same thing if you take someone, again, let's say hypertension is a paradigm. You can have hypertension and not have heart disease, but you could be at risk for it. You can get it later. I mean, some people with hypertension have it, some don't. Some have kidney disease, some don't. Some have other vascular disease, some don't. And so a lot of people with hypertension are going to manifest differently, different levels of severity, different treatments are needed. And it's really the same thing with PCOS. It's not the same for everyone. Some people have a very, very mild, or there's not a lot of systems involved and there's not much to do. And other people, it's affecting their whole body and their whole system. And it's a really significant problem and everything in between. And it's also, I think there is a misconception that it only happens to people who are overweight or obese. And that's not true.
That's not true.
Yeah.
It's called lean PCOS. Yeah. These are people who don't have excess body fat, but they still have, some of the same symptoms of PCOS. And I think they actually probably are more of a distinct condition, maybe more of like a true genetic component to it or, versus some of the other symptoms that we see.
Yeah, I mean, it's hard because since people sort of look different when they present symptoms-wise and sort of body types, and it does make it complicated. Another complicating factor, we sort of touched on it before, people disagree about what you need in order to have the diagnosis, right? There's even a lot of lack of clarity, I would say, or that's what the kids say nowadays, lack of clarity about how to even give someone that diagnosis.
Yeah. Well, there's a few different criteria. So I think the most widely accepted one that we use now is the Rotterdam criteria. That's what the American Society of Reproductive Medicine, I think, ASRM, that's what they use. And that, I think we just need to decide on one and stick to it. Yeah. And then, so that way we can be consistent in our diagnosis.
Agreed. Now, in terms of the cause, why would someone get it versus someone not get it?
So again, because it's a syndrome, right? There are many different causes. And so there are approximately, 20 known candidate genes. So it could be like very strictly genetic. You inherited this genetic mutation and you have PCOS. But there are also epigenetic changes, right? So these are changes that occur to your genes, your DNA, after, development, either in fetal life, like while you're a fetus, or even in your childhood or young adult life. And so those are by environmental factors. And then, I like to think of it as acquired PCOS. So if somebody, just different exposures and diet can also influence. So somebody may have never had PCOS, or they already had some underlying features, and then something changes in their life where they have a change in their nutrition or a change in their body fat mass, and now all of a sudden they have
Right.
PCOS. They
Right.
didn't have it before.
Again, similar to like hypertension. You can have it because my father had it, his mother had it, and I get it at age 20, even though I'm in perfect shape, whatever it is. Or it could be something that maybe you weren't quote unquote destined, genetically to get, but it's environmental. And there's obviously all the combinations.
Right,
you can have
in
these
between.
genetic sort of predispositions that you're going to get pushed over the edge quicker than someone else would. And this is true for most diseases. And it's hard to tease that out because they all play a role in a sense. Okay, so this is what happens traditionally. How is PCOS treated?
So traditionally, PCOS is treated by managing the symptoms. And so the most common, if we're talking about somebody's coming into my office and they're complaining of some acne and facial hair and irregular periods, we will recommend an oral contraceptive. And there's a few different good reasons for doing that. And I'm not saying that it's not the right thing to do. And that's historically what we've done because it solves a few different problems. It solves the problem of the irregular periods. It solves the problem of having too much estrogen and reducing that endometrial cancer risk, right? And it also helps with people's acne because that's another great side effect of the birth control pill. But then what happens is when somebody decides they don't want to use contraception anymore, now the syndrome comes back, right? The symptoms come back. So it may be insufficient.
And it also wouldn't really impact necessarily things like insulin resistance, risk of hypertension, those other problems.
Those other problems. If, then we realize, well, a lot of people with PCOS have insulin resistance. And so there's another medication that's commonly used called metformin, and that is an insulin sensitizer. And that's also a really helpful treatment. And those are still the mainstay of treatment for the majority of symptoms and for the majority of people. But it's, I don't think, enough personally. And I think people who have PCOS, in their experience, it isn't sufficient. And that's probably due in part to there's more to it, right? And also I think a little bit in part to education, right? Like, so I have a lot of patients will come to me and they'll say, I've had PCOS for so long and my doctor just said, here, go on the pill and lose weight and you'll be fine, right? And come back to me when you decide you want to get pregnant. And that's a very frustrating experience for the patients because they don't really understand why they, like maybe they don't want to be on the pill. Maybe they don't like it. Maybe they don't like the side effects. Maybe they're not sexually active. So they don't understand why they should be on, maybe they don't like to be on something, artificial hormones for whatever reason, because the education isn't there as to what it is and why we're using it and what the benefits are and, how it's reducing some of your health risks. And so, again, not to say that it's wrong or the bad, the wrong treatment, but that it's maybe just insufficient.
Well, I think also, what you're touching on is PCOS is really something that is a more global problem, right? And the global problem can have a lot of prongs that come out of it and manifest. And like you said, you can go after each of the prongs individually, and that's not wrong because if something's bothering someone, you can help them, great. But it's not getting to the global problem, number one. Number two, it also, people don't really understand why I'm having this. That's another thing. And the final part is, because of that, if let's say I'm a dermatologist and I see someone with acne and it's from PCOS, I, as a doctor, am only focusing on the acne and I'm only really trained to focus on the acne. I wouldn't expect a dermatologist to start going into all this and treating people, lifelong care for PCOS. That's not really their field, and that's fine. And so what happens is a lot of time this gets siloed. And so the gynecologist is like, all right, I will have jurisdiction over your periods. And the endocrinologist is like, I will have jurisdiction over your insulin resistance. And the dermatologist, I'll have jurisdiction over your acne. But no one is really either able to or willing to or even thinks about who's going to be in charge of this care globally. And that happens in a lot of conditions. It's not unique to PCOS, but this is one where since it crosses so many fields, like who's running the show here? And that's tough. Who should it be, right?
Are you like in my head? These are like my words. It's like you're saying.
It's just how we roll. Anyone who's come through, had to sit through my journal club Monday mornings, get tortured by me. I just feel like I have a link into your, into your central computer there. So this is a setup, obviously, for what you decided to do about this, which is
Correct.
awesome. So
Yeah.
let's come back from talking about PCOS specifically to what are you doing to make the world a better place right now?
So, thank you. That was a great segue. So I decided after working in a traditional office in a few different neighborhoods around the city that I was going to really hone in and focus on PCOS. And in order to do that, I needed to be able to have some more time, right?
Right.
So I decided that one of the beautiful things about the pandemic is that it forced me to use telemedicine.
Right.
And I hated it at the time because for many, many gynecologic complaints, telemedicine is just really not
Point
great.
the camera lower.
Yeah, it really was not doing it justice. But I actually discovered that this was a great way for me to meet with my PCOS patients.
Right.
And they were able, and sometimes it was even better because I was actually able to see them in their homes and see what they're eating and look at their kitchens while I was talking to them. And so that really opened up this idea that I wanted to start a telemedicine practice solely caring for PCOS. And so I did that.
Wow. So tell us about it. What's it called? Let's start with that.
It's called PolyPrep MD. So poly, it's a play on polycystic ovarian syndrome, but spelled P-O-L-L-Y, like the women's name.
Okay.
And then prep, because I want this to be sort of like a prep school. I want really the focus to be on education because I feel that's really my job. Educating about the condition, educating about the management, educating about the risks, and then MD, because I'm a doctor.
Because you're a doctor.
Because I'm a doctor.
Yeah. And so, all right. So that is what it's called. It's called PolyPrep MD, and that's also your website.
Yep.
And what happens on PolyPrep MD? What happens when someone finds you?
Someone finds me, and they can, if they're not sure about what I'm about, they can, make an appointment with me to talk to me for 10 minutes or so, and we can see if it's a good fit.
And this is all they sign up online. It's virtual.
It's all virtual, so it's all through the website.
There's
an online calendar.
You have no idea where you are. You can be right here, right now.
Correct. I can be here. I can be in Brooklyn.
Okay, got it.
Where I usually am.
Okay.
And then they can sign up and have a visit with me. And the initial visit takes an hour.
Right.
So
it's like a real consultation.
It's a real consultation.
Right.
Where I go through their history, their whole PCOS history. I review their labs if they, have gotten them to me in advance, which is helpful. And I do a full nutrition assessment. And so by the use of, my nutrition assessment history taking skills, and there's an app that I use called Diet ID, which also is another way to assess diet quality. And then together we come up with a care plan, and that can include nutrition recommendations. It can include recipes. It can include supplements. It can be adjustment of medications. It could be additional lab work. So all of it, medical care and nutritional care.
And so you're going to the top of the pyramid and working your way down. You're touching everything, right? And so you'll get into the weeds on nutrition and diet because you can.
Yep.
And you can also do that medically because you can, like you said, that's the MD
yeah.
part. And then what do you do in terms of is it like a full medical practice that you can order tests and you can get results and you can send them to other docors and you could do all those things.
So I can do all those things.
Right. It's a real telemedicine practice. It's not just like a neat service that people can get.
Yep. It's not just education.
Yeah.
It's not just coaching.
Right.
Yeah. I can refer them and I have a great list of referrals and I can send them to the lab and
you can prescribe
the medication, all of the things.
And then what else happens there? There's obviously an educational piece to you and to your website. How does that work?
So that's, just one-on-one, face-to-face education plus all the different tools that I send electronically. Patients can direct message me, which is great for them. They want that connection. They want to be able to follow up. And then I'm working on an online course for people, and I'm hoping sometime either this fall or early next year actually to do shared medical visits. And what shared medical visits are group doctor's visits. So
group of doctors or group of patients?
Group of patients.
Okay.
With
the last
me.
thing you want is a group of doctors.
No. Group of patients, right, that all have PCOS that want to go through a really much more intensive experience where they get to spend, 90 to 120 minutes with me over the course of several weeks, but also with their peers.
Right.
So it provides more education, right? Because I'm able to just get that much more information across in that time period, but also it provides peer support, which has been shown to be really, really important.
Yeah. I mean, people use it obviously if you're focused, let's say solely on weight loss, obviously peer support is a big part. That's how Weight Watchers sort of was successful. But this is, you're saying it's the same concept, but you're talking about for medical care.
Yeah.
That's pretty cool.
They're doing it a lot at Cleveland Clinic. They do it for diabetes and other chronic medical conditions. There's a prenatal care model called Centering Pregnancy that back in my dietitian days, I actually got to work with a midwife in Centering Pregnancy, which is group prenatal care. So honestly, it's really inspired by Centering Pregnancy, to be honest.
Wow. And now when did you launch? Recently, in
the last few weeks.
Wow. This is brand spanking new.
Brand spanking new.
And you have not otherwise retired from the rest of your practice of medicine, correct?
I am a laborist, which means I am an in-hospital obstetrician. So I still get to deliver babies and care for women in other ways and teach the residents. And I love that.
It must be awesome for you when someone comes in labor and you find out they have PCOS.
Like, yay, we did it.
Yeah. Wow, that's really cool. And so far, obviously, since it just started, I don't mean the response amongst like patients, but what has the response been from like your colleagues, your peers? Because this is a real pivot. Like most doctors aren't doing this, right? They're either unable to or unwilling to or afraid to or haven't even thought about these things. What has been the response when you talk in the doctor's lounge about this?
Some people are really excited about it.
I'm one of them. All right.
Cool. Great. Some people are really excited about it because I feel like it's a solution for them, right? If they have a patient who has PCOS that they really would like them to get good care, but don't have the resources in their practice, they can send them to me.
Yeah.
And I'm not going to take their patient because, I don't have a place to do a pap smear and I'm, so I'm not, they'll see me and they'll go right back to their physician. So I think that is providing a service to my colleagues as well. Some people are really excited about it. I keep bumping into people who are like, I have PCOS and I saw your Instagram and I think it's so fantastic what you're doing. So people I didn't, that I've known, but didn't know that they had PCOS.
Wow.
So that I've been able to impact people in that way is really excited. And there are some people that don't get it and that's fine. They'll, they will eventually.
Haters will be haters.
Exactly.
No one's a hater for this. I think it's really cool. So how do people find you? We mentioned there's the website.
Yep.
So which is www.polyprepmd, and that's 2 L's in poly.
2 L's.
And it's all one word, no dots, dashes, or anythings. Okay. And then you mentioned the Instagram. You got
Instagram.
Is it called a handle?
A handle.
Okay.
Dr. Basma Faris.
Oh, okay.
Yeah. So
got
that's
it.
pretty simple. That's the best place to find me there. And so I post about food and not just PCOS on there, but, nutrition and food and women's health issues.
It's amazing.
Yeah.
Where do you see this going over time? What do you think?
Honestly, my hope is that this is a model for other people to do something similar. So, right now I'm licensed in New York and Florida. Maybe I'll get licensed in other states if, the need is there. Or maybe I can convince some people in other states to come on board with me and we'll grow so that we can provide people, care across the country.
I think it's amazing. No, this is definitely, as you said, this doesn't replace certain aspects of medical care. It really just supplements and enhances, right? Because
I think so.
It gives people an ability to do this and different, from work, potentially from home. They can probably have someone Zoom in with them, and from different places. I mean, we found in our own practice, like for when I do consultations for pregnancy or pre-pregnancy, it's the same thing. It gives people access that they would never have otherwise, and the ability for them to see me, for me to see them. And it's great. Even though I am doing the same thing I was doing beforehand, it opens it up, but it's double. Not only are you opening this up to sort of everybody, it's also more comprehensive than what they're likely going to get from any individual sort of specialist.
I hope so.
Yeah.
Yeah.
See, it sounds that way.
That's
sounds
my goal.
Good to me. Wonderful. Thank you so much for coming on the podcast.
You're so welcome. I have to tell you something.
Oh, boy.
Your podcast was the gateway podcast For me,
I'm your sort of like marijuana that got you into crap.
Exactly.
All right, let's do it.
So I never listened to podcast. I was like, what is this podcast nonsense?
Yeah.
And I was like, well, if Nady Fox is doing a podcast, like he's probably got something to say. Like he's a smart guy.
If that idiot could figure out a podcast, I could probably turn one on and listen.
So I started listening to it and I was like, this is a really smart way. Like I would listen on my commute and I was like, this is a really smart way for me to learn stuff. And that just changed everything. I listen like almost exclusively, like I hardly ever listen to music when I'm commuting. I listen to podcasts and mostly like for learning. So whether it's medical related, science related, business related, you know, there's a lot of great information out there. And
it's awesome. When are you going to start doing your PCOS podcast?
I don't know.
Poly podcast. Wow. All right. There we go.
We'll think about it.
I'm planting a seed here.
All right.
You heard it here first, folks. There's a Poly MD Poly Prep podcast, the PPP.
I will give you the props that you deserve.
Ooh, the PPP, the Poly Prep podcast. Oh my God, that's awesome. Listen, really, thank you for coming here. Thank you for coming in person. I know we could have done this over the phone.
No, this is so much better.
So nice to see you. It's really a delight. I'm really looking forward to working with you sort of like day to day again on the labor floor. That's going to be
fun.
It's going to be really cool. And so for all you out there, either you
Journal
have PCOS,
Club,
if you have PCOS, you know someone PCOS, you want to learn about PCOS, check out the website, PolyPrep MD. Again, 2 L's in that poly. And I am certain you will find it really interesting and cool. Thanks.
Thank you.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.